Well, thanks so much for joining us. So I guess just for everyone, this is Dr. Greg Yurasek. He's one of our CI attendings, one of the cardiologists here at Children's. He is joining us today. We're going to go over some congenital heart defects, specifically the post-surgical congenital heart defects in these kids that we might run into in transport. I feel like we get some really good opportunities to do this education with cardiac stable, and we run into a lot of these kids pre-surgically with the NICU coming from next door, but we don't get a whole lot of opportunity for education once these kids have these surgeries and what to do with them whenever we go and pick these kids up at outside facilities. So is there anything you'd like to add on to that, Dr. Yurasek?
No, that's great. That's great. I'll qualify the hour just a little in that my kids are off today, so I'm kind of holed into my basement, my attic actually right now, which will be interesting. And also I have a bit of a cold, so my my stamina is a little low, but it's great to be here. And I think it'll be nice to talk to you guys a little bit about, like you said, Josh, transport and management, especially like crisis management in kids who've already had surgeries. And as we talked before, I'd love this to be interactive and have people on the call sort of feel very free to ask about certain defects or reminisce on experiences that they've had and say, geez, is this how this should have been done? Or theoretically speaking, what would happen if this happened? Like, I find that sort of learning is potentially helpful here. I think what isn't helpful is, banging through 60 slides in 60 minutes and going through all the congenital defects. I think that none of that ends up being retained. And so I have 0 slides. You're just stuck with me. So it's really up to you, Josh, if you want to kind of frame the discussion a little, and maybe just start with like a certain, constellation of lesions or a certain type of thing or a certain type of patient. And we could talk a little bit about that management. That's fine with me. It's really up to you. It's your hour.
Yeah. So I figured we might start off with kind of a brief overview of these common surgical interventions that we might run into, and then get a little more into detail based off what the actual cardiac defect is and the progression of the surgical interventions for each one of those and some of the troubles that we might run into. So the two I had laid out for us specifically today would be hypoplastic left heart and tetralogy of Fallot.
Great.
My personal experience has been we run into those the most often. I'm not quite sure what everyone else's experience, but if anyone else has different experience, I'd love to hear from that too. So specifically things like when we run into like BT shunts, Sano, Glens, and Fontanes and some of the various patches. So would you be able to go over like a brief overview of like what each one of these shunts, these surgical interventions, like the Glen and the bidirectional Glen and the Fontan and fenestration, kind of like a brief overview of exactly what these are, what they're skipping, and what sort of things, and then we can get into more detail based off the actual defect.
Of course, be happy to do that. I think when you start with something like hypoplastic left heart syndrome, the nice thing with that is you can actually think of a right-sided and left-sided problem at the same time. So you could think of something that would be like analogous to hypoplastic left heart syndrome, which would be something called tricuspid atresia. So in both of these cases, you only have one AV valve, one inflow valve, and typically one truly formed ventricle. For the purposes of transport and acute management, it really doesn't matter if it's a left or right-sided issue. What you want to know is what has been the palliative steps surgically that got the child this far. So in both of those cases, you're going to have one ventricle, and it's going to have to pump out a systemic output, and it's going to have to pump out a pulmonary output. The initial stage, the initial surgical palliation, and we use the word palliation as opposed to a corrective surgery because it's en route to something down the line. And because if you think about single ventricle heart surgeries, they're all palliative. The idea is to try to get the patient to their best potential as a human being and their best potential as a heart. The issue is not to make their heart look like yours and mine. That's not capable. We don't have the ability to grow ventricles and AV valves in 2022. Maybe someday we will, but we don't now. And so when you think of a child born with hypoplastic left heart syndrome, or tricuspid atresia, or anything where there's really just one ventricle, the first stage, and this is what we call the stage 1, is going to be the establishment of whatever blood flow you don't have to begin with. So if you're a hypoplast, you typically have mitral and aortic anomalies, often atresia, meaning there's no flow or there's no real development of those vessels or valves. And so your stage 1 procedure is going to be creating a systemic outflow, and that's called the Norwood procedure. And then the pulmonary outflow is going to come off the systemic one, and that's where you're going to have a shunt. The shunt itself can really come from 2 different things. One is it can come from a systemic artery and go to a pulmonary artery. That's called a systemic to pulmonary shunt. And we call that a BTT shunt. And it's really kind of nice. I'll just say anecdotally, something that's really changed in this business in the last, I'd say, 10 years is thinking of Vivian Thomas. And so, you know, the BT shunt was this guy named Blaylock. He's this real old Southern proper dude. He worked at Ole Miss, and eventually they convinced him to come over to Hopkins. And this woman named Helen Tausig, that's the first T, and she was actually a deaf cardiologist in the 50s, and women had absolutely no respect in medicine back then. They basically gave her a bunch of cardiac kids that couldn't be fixed and said, yeah, just figure it out, Helen. So she got this guy, Blaylock, to try to do systemic to pulmonary shunts because he was trying to do those in dogs, and he was having some success. And this guy named Vivian Thomas, who's the other T, is a Black man, and worked with Blaylock in his lab in Ole Miss, and was surgically very skilled despite having no formal educational training. And he came to Hopkins and performed almost all of the initial BTT shunts that we see. And I just want to mention that just because it's an amazing cultural thing. And I think we're finally trying to get smart enough to realize that the contributions in early medicine were not just by white men. And so I just kind of wanted to say that. Anyway, the BTT shunt comes from the something off the aorta. So it can be the carotid. It can be the innominate. The innominate, you may recall, is the common vessel of the carotid and the subclavian. And then it goes to one of the pulmonary arteries. Typically, if the child has a left arch and the innominate is on the patient's right, then that shunt goes from the right innominate down to the right pulmonary artery. So that's a BTT shunt. And the other kind of shunt is going from the ventricle right to the PAs, and that's called a Sano, named after a Japanese surgeon who perfected this technique about 20 years ago. So in either way, the ventricle is doing a whole heck of a lot of work. It's pumping blood out to this new aorta or neo-aorta, and then it's also pumping blood either directly to the pulmonary arteries or by way of a shunt to the pulmonary arteries. But it's a big, overworked, sort of underpaid ventricle. And the reason I bring this up is that is sort of the bane of the interstage patient. Interstage means between stage 1 and stage 2, which means something when you have a shunt. If you look at the allegory to the right side, like tricuspid atresia, may seem like this whole new anatomical ballgame. It's actually really not. In those diseases, the patient has a good aorta, but they don't have a pulmonary outflow. And so similarly, they need to have a shunt created from the innominate or some systemic vessel down to the pulmonary artery. And similarly, their ventricle is going to be really overworked. Lots of blood flow going in, lots of blood flow going out, as it is supporting 2 cardiac outputs, one to the systemic circulation and one to the pulmonary circulation. So when we think of interstage patients or patients who have a shunt, those are by far your most delicate kids. And if you're transporting a kiddo with an interstage circulation, there's a couple things you want to be made aware of. And I'll spend a bit of time on this because when it comes to the Glenn and Fontaine, the management is much easier because the physiology, if I had to use a word, is much more forgiving. But interstage kids are not forgiving. And in fact, in our institution, about 30% of interstage kids don't get home at all before their next operation. They kind of hang out in the hospital dealing with poor weight gain. Maybe they're stuck on a ventilator, maybe they're stuck on some high flow. Maybe they are having other residual disease issues that are keeping them in the hospital. But if you get a call and you hear that there's a Norwood with a BTT shunt or a Sano or any patient with a shunt, my advice would be, and you guys are so good at this anyway, make sure you contact the cardiac ICU attending. It's not that we know every one of these kids, but the thing is, in the DMV, people like me probably know every single one of these kids because there's not that many that we have. And the ones that we have, they have all come through our center and we basically know them all by name. So it can sometimes help to give us a call. It's a little different than transporting a trauma or really bad asthma or other stuff. These babies, they're going to be under 6 or 9 months old and we generally know them by name. We might be able to help you out a little bit and give you some guidance. The general principles of transport and acute management of a shunted patient or an interstage patient, I would say, are the following. The first thing is going to be, what is the child's breathing pattern and how sick are they and do they need to be intubated? Now you're thinking of that as a transport expert all the time, but with kids who have a shunt, they tend to be very easy to fluid overload because of that single ventricle doing all that work. And also they tend to deal with dehydration quite poorly. And part of it is because the shunt, of course, is just this Gore-Tex tube, 3 or 3.5 millimeters wide. It's really narrow. It's very easy to thrombose or clot if the child becomes dry. And so trying to figure out if you need to manage the airway is important because these kids tend to get pretty sick with just small perturbations. A little bit of volume overload or fever can get them really sick in one way. A little bit of dehydration, gastroenteritis, anything of that nature can get them sick the other way. So always call and let us know if there's a way that you think the child can be managed without intubating them. And the reason I mention that is because these kids are difficult to sedate. They've often been through the ringer when it comes to the medicines they've been exposed to. And they often do pretty poorly with the typical kinds of medications that we use to provide induction type anesthesia and paralysis in order to secure an airway. So if you see a child who's interstage, they're kind of doing okay, and you think you can get them to us without intubating, that'd be my strong advice. If you feel they can't, just try to make sure that in the institution that you're getting them from, if they've got peds anesthesia, if they've got ICU, anything like that, it'd be really important. And it's not that we don't have the fullest faith in your skills to manage an airway. That's not it. It's just the different medicines that we use are sometimes different in these interstage kids. So I think the number one thing would be, what's the kid's volume status and do I need to invasively manage the airway? The second one, and this comes up all the time, do I give them oxygen or not? I'll give you a really, really basic answer to that. And that's, if they're blue, give them oxygen, right? So if their SAT is 65%, please put oxygen on them. You cannot harm them. If whether you're supposed to be 78% or 98%, if you're 60, you're cyanotic and you need oxygen. In the interstage kid, you may need to do more than just oxygen, but please, if the patient is cyanotic, provide them with oxygen. Feel free to call us, but we're going to tell you the same thing. The third thing is probably, do I give them volume? This is always the thing in the ER. Patients come in with really almost any heart lesion, and there's an interesting theory, and it's easy for me to sit back just because this has been my whole training. Trust me, if you gave me a X24 weeker, who's 3 days old, and I'm trying to figure out how to ventilate them, I would really not be comfortable in that situation, and I would call a neonatologist. Similarly, if you have a kid with significant heart disease in the ER or outside, feel free to call us. That's what we're here for. So by no means am I saying I know everything about this stuff. I don't. I just know a lot about this one thing. When it comes to heart lesions that involve interstage providers, whether they're working on transport teams or they're working in the ER or they're working in the NICU, tend to be terrified of giving kids fluids. This I don't exactly understand. It's sort of been propagated through the years, but I would use the same theory here as with oxygen. Do you think the child is dehydrated? If you think the child is dehydrated, you must give fluid. It does not matter if they have one ventricle or two, if they have a shunt, if they have a Glenn, if they have a Fontan, we'll get to those lesions too. A dehydrated patient needs fluids, period. I would just qualify that by saying, if you feel the child is very dehydrated and they have an interstage physiology, an interstage circulation like a shunt, keep in mind that those patients tend to get fluid overloaded and get some fluid in their lungs if you give them a lot of fluid. So you would want to have a good contingency plan. If we're going to give this kid 20 per kilo because, oh my goodness, this baby is super dehydrated on my exam, tachycardic, hypotensive, dry mucous membranes, whatever it is that you're using to sort this out, keep in mind that their respiratory picture may worsen if you give them fluid, and let us know if you need to give them some fluid, because we might be able to help you out there. So I think the three things that come to mind are, if I don't need to intubate, don't intubate. Can I provide this kid with some cannula oxygen or anything that's non-invasive and just get them where they need to get? Number two, if they're blue, give them oxygen. Don't worry about what their circulation is. Give them oxygen. And number three, if they're dehydrated, give them volume. Call us about these things, but I don't want folks to feel shy about doing because the first principles still apply even to shunted patients. I think those are kind of the main three things that come to mind with an interstage kid. Everything else from a transport team standpoint would be the same. Make sure you have good IV access. If you don't, get an IO. If you don't have either, have an IO ready. Make sure you're traveling with fluids, that you're traveling with code dose epi, that you're traveling with airway equipment. You don't need me to tell you this, of course you would. Those are sort of the main things that I think of when you're considering an interstage kid. You're not going to see that many of these kids on the outs. You're going to see Glens and Fontans more, but I wanted to spend some time today on interstage kids because they tend to be the most fragile. Any questions, Josh, or anybody before we move on to the Glens and Fontans, which I'm going to group together?
Do we feel like the airway support for these interstage kids, we follow the same escalation pathway as a normal kid? Like we escalate first to high flow nasal cannula up to 2 per kilo, then up to BiPAP or RAM, depending on the size. Would it be like the same escalation pathway for these interstage children?
Absolutely. Great question. Yep. Absolutely. I think that if you're to the point where you feel the respiratory effort is pretty compromised or the kid's retaining CO2, that's probably worth a conversation, because putting, as you guys know better than I, putting a BiPAP mask or any sort of like true positive pressure, so not high flow, but true positive pressure, non-invasively on an infant is really hard. You don't get a good seal. You don't really know what's going on. They're just kind of crying in the mask. You're like, I think this kid's probably okay. Maybe the SAT probe's picking up. Maybe it's not. If you're about to do that sort of thing where you're going to put a full mask on an interstage kid, do give us a call, because that is a case where if that's your judgment, we may want to think about intubating that kid for transport. Good question.
Okay.
Any other questions before we move to Glens and Fontans?
I have a question.
Of course.
When you say these kids only have one ventricle, is it more common to have just the right one as opposed to the left, or?
It's a great question. So, it's like one of the cruel things about, embryology here is it's between 5 and 10 times more likely to have issues on the left when it comes to ventricular substrate and AV valves than on the right. And the reason that's a bummer is because the left ventricle is the systemic ventricle, right? And so it's more common to have a hypoplastic left heart variant. That can mean mitral atresia. That can mean aortic atresia. It can mean no left ventricle that's appreciably there, or a really small one. Those diseases, although rare, are much more common than the right-sided counterparts. And on the right side, it's pretty much this thing called tricuspid atresia, which usually is accompanied by a really, really small, like primitive right ventricle. Those patients tend to do better because they are born with a good left ventricle and a mitral valve. The way luck has it, the way embryology goes, and we don't exactly understand why, there are a few series that have looked and said there's almost 10 times as many patients in the hypoplastic left heart delegation than there is on the so-called hypoplastic right heart. Other questions? That's a good question. So Glens and Fontans, what I could say is if you hear that there's a Glen or a Fontan that you need to transport, take a deep breath, because it's going to be okay. It's going to be okay, because these patients are quite forgiving. And keep in mind, in a weird sort of way, I say this to the fellows all the time, they've kind of been through boot camp. They may be sick, they may be dehydrated, they may have terrible asthma, they may be having new arrhythmia, new dysfunction. If you're transporting them from hospital to hospital, they're sick. There's no question about that. But these kids have already you already have a significant selection bias for these kids to good. And that's because they got through the neonatal period when they got a Norwood or a shunt or some major neonatal surgery. They got through the interstage period, which is when the majority of our mortality in single ventricle palliation, the majority of the mortality is in that interstage period before the Glenn. They got through their Glenn or their Fontan, and now they're on the outside and they got sick. Just to keep in mind, I think you guys know this, the Glenn just means you take the SVC and you take it, basically it's taken off the roof of the right atrium and tacked into the superior margin of the right pulmonary artery. That is, SVC feeds the PAs and the pulmonary blood flow becomes so-called passive. And then if there was a shunt, that's removed, ligated and clipped and taken out. A Fontan is the same thing, except now, in addition to the SVC, the same principle, the IVC is brought off the floor of the right atrium and brought into the underside of the right pulmonary artery. And if you're a Fontan, all of your systemic venous drainage, arms, head, legs, trunk, belly, are going to go into the Fontan pathway, IVC, SVC. They're going to bypass the right atrium where they're normally supposed to go and go right into the lungs, come back from the lungs into the heart, and be pumped out to a single systemic output from there. So there's no more systemic to pulmonary shunts left in a Glenn or a Fontan. It just means you've taken the great veins and you've tacked them directly into the lungs. These kids tend to be pretty robust. Keep in mind that whether you're a Glenn or a Fontan, some people would divide these two. I think for the purposes of transport, it's really not that important. If you need, let's again go through the oxygen, volume, intubation. I kind of think, Josh, if that's okay, I kind of think of those, the transport I used to do when I was a fellow at Mass General, that was kind of the things I would think of, like after access, which is obviously probably the most important thing. How much oxygen can I give this kid? Do I need to intubate them? And do they need a lot of volume? And can I give it safely? Those are sort of the things that I used to think about. When it comes to a Glenn or Fontan, volume is key, okay? You need good, juicy SVC return, and in a Fontan, good, juicy SVC and IVC return, not just to provide pulmonary blood flow, but imagine yourself as the ventricle in a Glenn or a Fontan. The only way you get blood into yourself is if blood goes through the lungs, right? There's no more blood coming back into the right atrium anymore. It's all coming back from the lungs. So if the Glenn or the Fontan circuit, which is another way of saying the great veins, if they're dehydrated, the patient won't just be blue. That is, they won't just have inadequate flow to the lungs. They'll have inadequate return from the lungs, and they'll be in shock as well. They won't just be blue, they'll kind of be gray. And that's a bad look. So if you see a Glenn or a Fontan, and they're out in the field and you're picking them up for whatever reason, arrhythmia, could even be a trauma, respiratory distress, probably the most common one. Dehydration is your enemy. Giving them fluid is your friend. They will tolerate fluid, and they will often tolerate a lot of fluid quite well. Very different than an interstage kid. When it comes to oxygen, same principles apply. If blue, give oxygen. If not, don't. I'll only add in the Glenn and the Fontan, you can't give them too much oxygen. Don't worry. If you have a Glenn saturating 97%, it's fine. For a period of time, it's fine. For a few hours or a couple, it doesn't matter. If you have a single ventricle interstage saturating 97%, that could be a problem, and which is why we spent some time on the interstage kids. So if it comes to volume and you got a Glenn or Fontan, your default is yes. If it comes to oxygen in a Glenn or Fontan, your default is yes. Intubation is interesting. I would say it's not many Glenns and Fontans that need to be intubated for transport. Now, it's one thing if it's an automobile accident and there's terrible trauma and they need to secure the airway for that sort of thing, or there's an ingestion and the child's not breathing. But if it's a respiratory problem, and again, most of them are, or a rhythm problem or a dysfunction problem or any of those common things that we see, typically these kids do pretty well with non-invasive ventilation, meaning some cannula, some high flow, an IV, and a decent amount of hydration. That'll get the great majority of these kids through. And that's mostly because the ventricle itself in a Glenn and a Fontan is not pumping out blood to the lungs and to the heart I'm sorry, to the lungs and to the body in a systolic fashion. It's pumping blood out to the body, and through this Fontan or Glenn pathway, there is passive blood flow coming into the lungs. And that's the main reason that the Glenn and Fontan circulations are a lot more forgiving. Where you can get in some trouble is if you have a Glenn or a Fontan, especially a Fontan, and you feel you need to intubate them. Let's say this is, you arrive on the scene, you get a basic story from the mom or dad that this child has a Fontan circulation and they are in extremis, or they are obtunded, or they are comatose, or there is an issue where you need to manage their airway right now. No phone call can be done. You're getting the laryngoscope out. Somebody's getting ready for compressions. Somebody's putting an IO in. Somebody's getting ready to intubate. This is the serious stuff. You guys do this and you do it well. It doesn't happen much, but when you have to do it, you have to do it well. If you are providing invasive ventilation to a Glenn, or especially a Fontan, you are going to need to give them generous amounts of volume. If there's one thing you take from this hour, I would like you to take that back. So I'll just say it again. If you're going to provide invasive ventilation to a Glenn or a Fontan, especially a Fontan, you need to give them generous amounts of volume. Why? Well, it kind of makes sense. Remember, all of the blood flow from the SVC and the IVC is going to go to the lungs first before it comes back to the ventricle. Well, when you ventilate, right, as I'm sitting here, even though I have a bit of a cold, I'm still a negative pressure breather, right? And my intrapleural pressure is probably -3 or -5 centimeters of water, as is everybody else's that's on this call. Now you intubate. Your intrapleural pressure is 10 centimeters of water or more, probably more because you're pretty juiced because you just put a tube in there and you're likely bagging at somewhat high pressures. I've been there. I do that too. When you increase the lung pressure, you are decreasing the venous return in a major way because you can't get the blood from the SVC and IVC to the lungs, and therefore it doesn't come back from the lungs to the body. That's the reason you need to give lots of volume to a Glenn or a Fontan if you intubate them. I really want to make sure that that point is made. So just to review with the Glenn and Fontan, the three things: oxygen, if blue, yes. And is it safe? Always. Volume, always. And is it safe? Essentially, always. Intubation, generally you don't need to, but if you do, be sure to provide adequate volume resuscitation. Questions?
Do we need to consider volume when we do other modes of positive pressure, like BiPAP? Do we really need to consider volume resuscitating these kids as well?
Excellent question. I like that, Josh. That's really good. And remember that if you're dealing with a Fontan, it's probably a patient who's 3 years of age or more, certainly at least 2. So what if you have a compliant 15-year-old girl who's got a Fontan and's got pneumonia? And you're like, well, I don't think she needs to be intubated, but her SAT's like 80 and she's breathing 27 and she's 15 years old and she doesn't look that great. I think I want to try some BiPAP. Great question. Same principles would apply. If you give BiPAP, you will be providing not as much, but some positive pressure in the thorax, and you will be impairing and impeding pulmonary blood flow and therefore pulmonary venous return. So if you're going to put a child or a teenager on BiPAP with a Glenn or a Fontan circulation, I agree. I would also be ready to give generous amounts of volume. And by generous amounts, I'm not talking about like 80 per kilo. I mean 10 or 20 per kilo at a time, just to make sure that the kids are doing well. And remember that if you have a Glenn or a Fontan, as you give that volume and there's more blood going to the lungs, the saturations will come up. So you can sort of titrate your volume resuscitation strategy depending on saturations. We sometimes say, it's very crude, I don't much like this, but I'll say it because you've probably heard it before. A dry Fontan is dead Fontan. I really don't like that, but I'll say it. Just goes to show and goes to say you gotta make sure that the Fontans don't get dry, especially if you're invasively ventilating them. So just make sure that you're thinking about access and volume first on those patients before you're thinking about any kind of positive pressure. Other questions?
Is there any time to consider pressors with increasing their systemic vascular resistance in order to kind of get that downflow effect and increase their preload? Yeah,
I'm glad you asked that. So starting, I would, sometimes these are always so hard because the kids that you're going to see it's going to be super rare that you're going to run into these kids. And it's hard to bucket them because they're probably all going to be really different. In general, starting a low dose vasoactive on any patient with a low blood pressure is reasonable. And I don't think from a transport standpoint that there's a better medicine or a worse medicine or a no-no medicine or like a catch-all medicine. If you have, whether it's an interstage kid, a Glenn, or a Fontan, so this would go for any cardiac patient at all, but we're kind of starting with single ventricle. Any single ventricle, and you get your first cuff blood pressure and your first purple number is 68/35 in a 5-month-old, or it's 72/50 in a 12-month-old, or it's 91/68 in a 16-year-old, and you're like, the kid's looking at me, breathing, crying a little bit, not toxic. Should I do something about it? It is not wrong to start a little bit of epi, 0.03, 0.05. We dose vasoactives in mics per kilo per minute. I didn't know this. It's really easy for me to do that stuff. I have a pharmacy and it's all I do every day. It's a lot harder to draw these meds up yourself as a transport expert. But 0.03, 0.05 of epi is a great place to start. You can also then, you have 2 ports in the bag. You can pull from the bag and bolus if you needed to give co-dose epi. I think that having a little bit of epi running in a lot of these kids is not really a bad idea. Similarly, if the blood pressure is normal, I probably would not start any vasoactive. I would just wait until the child arrives. It'll just be a little bit easier, once they get there, just because we have all the stuff in the Pyxis and we can just hook it up and it's very, very simple. But I like that question, Josh. And I think if the blood pressure is low, first principles apply. A little bit of volume. I don't know if I want to give a ton of volume to this kid. Starting a little low dose vasoactive support and cycling your cuff every minute is a really good idea.
Great, thank you.
Other questions?
Hey, this is Ben.
Hey, Ben.
For the kids that you are planning on intubating and you're not about to do CPR or anything, so you have a little more time, would you do more of a titrated induction? Are there certain drugs you would use or avoid? How do you end up intubating these kids?
Great question. Wow, that one's hard to answer quickly because again, it's each child you might be in a situation with where their single ventricle physiology and need to be intubated is probably going to be a lot different than the last one and the next one. I would say this. If you're dealing with a patient with normal systolic function, and you're going to have to either trust a mom or a dad to tell you that, or the provider at the hospital, or maybe you're able to get into the electronic medical record, or maybe you call us en route and say, I got Charles Smith here. I think they're a hypoplast. Sounds like they're very, very sick. Can you just see what the most recent echo is? And we can get that for you in like 10 seconds. Good RV function. Good. If you've got a kid with good function, I think standard induction is probably fine. And you'll have to remind me, in the field, if you're intubating, say, a kid less than 6 months or a year, are you using like fentanyl? Are you using ketamine? What's the most common? Are you using propofol? Like, what's the most common drug you would use for an all-comer 4-month-old who needs to be intubated? No heart disease.
Probably like Versed fentanyl.
Versed fentanyl. Okay.
Yeah.
And what if they, like so many of our children do, laugh at the fentanyl and the Versed?
We would probably try some more of the same drugs before
Okay.
moving to something else, as long as they could tolerate it. And then some people might move to a paralytic pretty quickly.
Okay.
But we also,
Totally
we have ketamine. We don't generally use propofol though.
Yeah, totally reasonable, Ben. And I think the principles that you guys have as a transport group and the amazing work you do with that, they really apply to cardiac kids too. I don't use a lot of propofol either. I do use a lot of ketamine. And I'm just going to give you this as a subjective thing. This is not evidence-based medicine. This is just in my experience. I like the overall profile of ketamine because it tends to keep their hemodynamics pretty stable. It might make them a little hypertensive, but not much. It raises their heart rate a bit so that the IV that you put in is working. I kind of like that.
Mm-hmm.
It can increase their secretions, as you guys know. But often if I'm intubating a kid, I will actually, as I'm bagging them up with end tidal, I'm seeing good chest rise. Before I'm going to take a look, I'll go down with either a firm tip suction catheter or even just an NP suction, just see how bad it's going on down there. Then I'll rebag them with end tidal so that when I know I take my look, it's going to be clean. And I think you can do that with ketamine. I cannot think of the last time that I found an airway. Plenty of times I've been in situations where an airway has been difficult, but I found an airway difficult exclusively due to secretions, and I'm pretty sure it was just the ketamine. I think ketamine's a pretty good drug, and I think for our cardiac kids, it is a good one. I say that only for two reasons, Ben, and this is not at all saying that fentanyl and Versed aren't good induction drugs. They're great drugs. One is Versed tends to drop your blood pressure a whole heck of a lot, and if you're intubating a cardiac kid, hypotension is not often the best thing. The other is you don't really develop this thing called tachyphylaxis, which is sort of like a dependence on ketamine like you do fentanyl and Versed. And if you've been exposed to benzos and narcotics throughout your life, as a lot of these kids have, you would find that, like, let's say you've got RSV bronchiolitis, 8-month-old, totally healthy kid. You give that kid 1 mic per kg of fentanyl and they're like toast, right? You're going to paralyze them and intubate them, right? It's very easy, maybe 2 mics per kilo, usually not that much more than that. Our cardiac kids, I find that it takes a whole bunch of fentanyl, a whole bunch of Versed, and it's not that it takes so much medicine that's causing time. Now you're bagging, the belly is blowing up. You know that your conditions for intubation aren't the same as they were 45 seconds ago, 1 minute and a half ago. Do you know what I'm saying? And what I like about ketamine is I'll just give 2 per kilo. I don't give a half per kilo, 1 per kilo, any garbage like that. 2 per kilo induction dose. They're out cold, almost any kid. Do a little suction, make sure the secretions aren't too bad, muscle relax and intubate. I find that that's helpful, and I don't want you to rewrite or recreate your own airway management skills as a transport expert. I would say in cardiac kids, my experience has been to try to use one med, and that one med for me has often been ketamine because it's one and done, 20 seconds, they're out. Another med that I used a bit for different reasons, this would be in someone where the systolic function is not good. And these kids, we get a little bit concerned about ketamine because there's this idea that like it kind of wastes through whatever catecholamines you have left. It's a poorly described phenomenon, but I've seen it. It's this idea that you can give a kid ketamine who's got, let's say you've got a kid who's a Glenn with bad RV function, and you give them ketamine and they're like in extremis. When you give it to them, their blood pressure can sometimes go down because you've basically just spent all the rest of the catechols that they had when you do it. I bring this up not as a don't use ketamine thing, but etomidate can be a really good drug in a patient who doesn't have good function. It's super duper hemodynamically neutral. Give a whole dose, 0.3 per kilo, don't give a half a dose, and they will be gone in 20 or 30 minutes. That's minutes, seconds. And you can paralyze them and all the other stuff. With etomidate, you can have like adrenal issues, but they don't happen instantly. If you come to the unit and you tell us you gave them etomidate, we'll typically give them a little bit of hydrocort and they'll be fine. So to answer your question, I think ketamine is a great profile drug for young kids, which is not to say that fentanyl and Versed are bad. They're not. And I think etomidate is a pretty good neutral drug for a child with dysfunction.
All right, thank you.
You're welcome, Ben. So do you want to move on to, we've got about 15, 16 minutes. You wanted to talk, Josh, about, was it canals or switches? What was the other one?
Yeah, so the next one I had was tetralogy of flow, and kind of this like early stages. Like I know they're very similar with their BT shunts. So are we treating these kids very similar with their BT shunts in this interstage? Are we more treating the underlying cardiac defect, or are we more considering what the actual surgical intervention has been for them? Great
question. So when you think of a TAP, right, you think of, we think of these 4 things. But what I always say to the fellows is tetralogy is not 4 things. It's just one thing. And that one thing is a certain kind of VSD. And it's a VSD that's big. It tends to spring the pulmonary valve forward. As it does so, there's pulmonary stenosis. The RV becomes thick and the aorta gets to the right and is overridden. So all the things that make up a tetralogy, don't worry about that. Just think big VSD. That's all it is. It's just a certain kind of VSD. It's a VSD that makes kids blue. So typically for tetralogy of Fallot, kids are repaired completely at about 60 to 90 days of age. If they're so blue that they're stuck on prostaglandin, that is, their pulmonary stenosis is so severe and the pulmonary valve is so narrow that they need a ductus to provide their pulmonary blood flow, those kids end up getting repaired early. And that's my problem, not yours, because these kids are usually pretty sick and they'll get repaired at about 5-6 days of age. But they stay in the unit. They don't go home. Or in, like you just said, just they can get a shunt. There are tetralogy kids who get a shunt. Just to keep in mind, is the same BTT shunt. It goes from typically the innominate artery to the right pulmonary artery, and it provides pulmonary blood flow. The reason that a tetralogy patient is going to be a heck of a lot more stable than an interstage is the ventricular substrate. In the interstage kid, you got one ventricle pumping out to the aorta, and it's also got to get the blood to the shunt. In a tetralogy, there's nothing wrong with the right ventricle. It's not small. It's actually big, and it's strong, and it's under systemic pressure. Both ventricles are pumping blood out to the systemic circulation, out to the aorta, and then there could be a shunt that's coming off of that. The reason I think that's important is understanding the anatomy behind a TET with a shunt makes you realize that a TET with a shunt should be able to handle all of the interventions that we just discussed a lot better. Dehydration, better. Arrhythmia, better. RSV, better. If you have a TET with a shunt or a completely repaired TET, and they're in the outside and they're a little bit blue, you pretty much can think of them as a normal patient that you are trying to provide care for. If they have a shunt, some of those principles that I mentioned before, like making sure they're, hydrated enough to get enough blood, through the shunt so things don't get clotted off, is important. But in a tetralogy kid with a shunt, you probably will not be able to fluid overload them by giving them volume. You're not in that danger zone of the interstage kid. Similarly, if you're dealing with a tetralogy patient who has a complete repair, right, which means the VSD is closed and the pulmonary valve is opened, think of that child as a normal child. Whether they're 6 months old or 6 years old, they may not do as well from an RSV or pneumonia or trauma or any standpoint because they don't have as much reserve as your average kid. But when it comes to giving them sedation, volume, oxygen, and all the things that you do, go with your first principles. If they're blue, give them oxygen. If they're volume low, give them volume. If they need to be intubated, just do it. You don't need to necessarily call ahead or think about a lot of those complex things that we talked about in the first half hour. And I don't have much more to say about TETs. If they're repaired, proceed as you will. If they have a shunt, I would keep them pretty plump, keep them with good volume. Was there anything specifically about TETs you wanted to ask, John?
No, I think that covered it very well. And that also kind of covered one of my other later topics of dealing with the full-grown adult that we end up seeing.
Yeah.
A lot of these, I presume, would be TETs who have been fully repaired. So we're treating those adults just as normal adults.
Good question, Josh. And, what we see, it's really funny, if you've, look at the idea of, when did we start doing complete repairs for tetralogy and really have it down? It's not actually that long ago. And so a lot of patients who might be over, say, 30, it's not that old, at least I don't think it's that old, with a complete repair TET, if they're less than 30, they probably had a complete repair on the get-go. If they're more than 30, they probably had a shunt and they probably took a couple of stages to get their complete repair. What we're learning, though, is that tetralogy patients specifically, and I bring that up, as you guys know, tetralogy is our most common heart disease that requires intervention, right? The most common heart disease is a VSD or an ASD, depending on who you ask, but not all of them require intervention. The most common disease that requires intervention is tetralogy. The most common cyanotic heart disease is transposition. But you're going to see a lot of tetralogies out there. And if they're over 18 or 20 years old, what we've been learning in this field is that a decent amount of them, for reasons we can't explain, develop significant ventricular dysfunction and end up needing heart failure meds or potentially ultimately a transplant. It often happens later in their life than 20, 25, 30 years of age. So this happens with adult congenital disease. It's not something I deal with that much. The only thing that I would use that for to qualify what you just mentioned is if you have, is a repaired TET, he's 24 years old, but he's takes some carvedilol and he's got a little bit of arrhythmia, he takes sotalol, but otherwise okay. Give a call, because you're going to want to know if that patient's function is okay. Not every TET, even though you're like repaired TET should be good. A lot of these, ladies and gentlemen who are 20, 30, or 40 years old develop for reasons we don't know biventricular dysfunction. And if they do, think of this now as a patient not with repaired tetralogy, but with ventricular dysfunction. So be judicious about the volume. Think about if you had to intubate them, think about things like etomidate or sort of cardio neutral meds. Think about calling ahead to be able to see if their function is okay, or how serious their medical history is. Are they a TET who got repaired at 6 months and they see a cardiologist once a year? Or are they a TET who then got a pacemaker, who then got a pulmonary valve replacement, who is seen by Anita John in clinic, twice a year? Those patients would be just different. So sometimes, Josh, the plumbing can be perfect, but the underlying function in some of these older adults, young adults, older kids can be imperfect.
Great. And I think just the last thing I had on my list was, are there any other things that we haven't talked about to consider, like any of these patches or like the transannular patch or VSD patches? Are there any of these that we need to really consider and think about and have great discussion when we're going to pick up these kids who have just had a simple VSD patch, or any of these other repairs that we haven't talked about yet?
Sure. So with a patch, you don't need to worry about that, I don't think, too much on your end. Patches are used when holes are big, and we don't think we can repair them with the child's own material. So for example, if you take an atrial septal defect, most of those, when the surgeons go in, they sort of harvest the pericardium. They put it in this stuff called glutaraldehyde, which sort of like decellularizes it and makes it like fibrous, and they close the hole with that. It's a beautiful thing. The patch grows with the patient. They never have any prosthetic material. But if you have a VSD, you typically need a patch, which is Dacron. It looks like Gore-Tex, and that's used to close the hole. The reason you use that is it's too big to just use something autologous or from the patient, and the pressure is too high to just put in pericardium because the sutures could come undone and stuff like that. The only thing you really need to know about patches is that sometimes there's a patch closure of a VSD, and sometimes, as you've alluded to, a patch is used to open up the pulmonary artery and the pulmonary valve, and that's a surgery called the transannular patch. Transannular patch means across the annulus. The annulus is the ring of tissue the valve sits on. The surgeons do a tetralogy. They cut into the pulmonary artery, open it up, take the crummy valve out, throw it in the garbage, make this like, it looks like a diamond. It's not a very good diamond, but it looks a little bit like this patch. And in doing so, they make the pulmonary artery back into a cylinder. So there can be a patch there. There can be a patch across the VSD. That's for tetralogy. If you had a canal, there's often a Dacron VSD patch, and then an autologous pericardial ASD patch to close that. But all you really need to know about patches is that kids with patches are a higher risk to have patch dehiscence, or holes that develop where the patch used to be. Again, more of a my problem than yours. And also endocarditis. And again, more of a my problem than yours. But it's good to know where the patches are so that you know the surgical procedures, but they shouldn't affect your transport or your management of these patients.
Going a little bit back whenever we were discussing the Glenn and the Fontan, in some of my previous transports, I feel like people have gotten fixated on whether the Fontan is fenestrated or not. Does that even matter to us in transport with these different considerations?
Great question. Great question. And it does. And I'm glad you're bringing that. So a fenestration basically means that when they bring the SVC and IVC together, it is going to take all of the systemic blood and it's going to put it into the pulmonary arteries. And if it's a patient who's had a good palliative process until then, healthy lungs, nice juicy PAs, it's going to work great. What the fenestration does is, as the IVC is tunneled up into the pulmonary artery, a punch is made between the IVC and the right atrium. And sometimes it's a patch is cut in that punch. Sometimes a stent is used. There's different ways to do it. What it allows to do is what allows to happen is if the Fontan pressure, if the SVC and IVC pressure gets high, and that could be any reason, lung disease, high pulmonary vascular resistance, cyanosis, a million other things, then that blood from the fontan, which is going to be dehydrated blood, deoxygenated blood, is going to shunt into the common atrium and allow there to be improved cardiac output at the expense of more cyanosis. So it's a right to left shunt. You're going from your IVC blue blood into your common atrium, mostly red blood, and that's going to go right out to your ventricle and out to your body. The fenestration allows the patient to be bluer, which is the bad part. The benefit is it gives them better overall preload to the ventricular substrate. From your standpoint, it's simple. If they have a fenestration, ask their parent or their provider what their SAT typically is. It's going to be lower. If they have a fenestration and they are relatively close to their surgery, let's say it's a fontan who got a fenestrated fontan 3 months ago, it's probably open, and they probably live with a saturation in the high 80s or low 90s. That'll help you know how much oxygen you need to give them, and it'll help you to know how sick they are. If they don't have a fenestration, then think of them as a circulation with no shunts. And the kids without a circulation, this is kind of a good take home, I think, without a fenestration, are the kids that are going to be most likely to get in trouble if they're dehydrated, because the blood is just stuck on the pulmonary side and the ventricle is not going to get enough overall preload. So to answer your question, just one little bit of detail. If you have a fontan and they need to be intubated or put on BiPAP, ask about that fenestration. If they have one and it's open on their last study, accept lower saturations, and maybe they don't need as much volume. If they don't have a fenestration, these are the kids that probably are going to need a lot of oxygen and a lot of volume to be safe if you're going to have to invasively manage their airway. Other questions?
Great.
Could
thank
take
you
one
so
more. I
much.
have a meeting at 2, but I'd be happy to take more.
That's all for me. Does anyone else online have any questions?
I had just a quick question you can answer in 30 seconds.
Sure.
Sodium bicarb, is that pretty much safe for any kids that we give it to, the cardiac kids? Because it seems like it's kind of avoided in the NICU, but as far as when they come to the SICU, it's more, we seem to give it more often.
Great question. Yeah. I mean, we use too much bicarb in the CI for sure. We're like addicted to perfect pHs. You know, we will not accept. It must be 740. You know, it's really interesting, and I'll just mention that there's some very interesting literature on this in cardiac patients. The NICU has been ahead of us when it comes to exogenous and extraneous use of bicarb for a while. And they basically there's decent data that bicarb can be harmful for babies, especially CO2 retainers, as NICU babies often are. Well, we've learned a little bit from a heart standpoint, and some of this is animal data, but some of this is not animal data, is that bicarb itself can actually be transiently cardiac deficient. It can cause less solid squeeze. The idea is acidosis can actually be causes a bit of a stress reaction, which is ideal if you're sick. More catechols, better squeeze, right? As you artificially make the pH perfect, it may actually lower overall cardiac function. So I think of it as, to me, bicarb would be if the number is really bad. If it's a kid that's under 720, say, and they have a base deficit, you should probably give them some bicarb. The reason for that is, as they get acidotic enough, the heart will eventually just fall apart. But if they're like 732, and whether it's 732-38 or 732-55, I would not give that kid bicarb, if that makes any sense. And I think 10 years ago I might have. I think that kid is 732. They're trying to tell you that they're 732. A little bit of acidosis might be helping them for the next hour or two. And I would just get that kid out of there and, bring them where they need to go. And I'm glad you asked that, because I probably would have answered that differently when I was training. Great question.
Thank you.
Any other questions? It's just about 2. I'd be happy to do this again, Josh. I love working with you guys, and it's the rare patient that is brought over from our transport team that is not resuscitating, and that is not everywhere. You guys do a great job, and whether you're bringing over a brand new baby or a medical patient, who's sick and is at another hospital, it's always great working with you guys, and I'd be happy to do this. Also good to get a different perspective, because cardiac intensivists, we're a weird bunch and we all do stuff a little bit different. And we're always kind of convinced we do it the right way. It's probably not true at all. But if you give me enough lead time, I could see if one of the other CI attendings would like to give one of these talks, and you might just see things a different way. It could be really good for you.
Yeah, I certainly appreciate your time and expertise.
Absolutely. It's a pleasure, guys. I'm going to step off. Thank you so much for joining today.
Thanks.
Thank you.
Bye, guys. See you.
All right. Thanks, everyone.
Here.
Thank you.
Well, begging 911 to